Good afternoon. This is Dr. John Bennett, televising from Miami. Today we're going to be interviewing Carlos Yumaguano, MD, a neurosurgeon originally from Spain, but now in Ecuador. And we're joined by a few guests. First, we'll go around and introduce the guests. Will introduce themselves. Why don't we start with you, Nancy?
Hi, I'm Nancy Berquist. I'm in Colorado Springs, Colorado. I have a history in chiropractic. I am a PhD candidate and finishing medical school.
Welcome, Nancy. Eleonora?
Hello, I'm Eleonora. I'm a sixth-year medical student in Rome, Italy, and I'm interested in neurology.
Welcome, Eleonora. And Simon?
Hello, everyone. My name is Simon. I'm a developmental psychologist, second-year med student, and a FDA correspondent for a bone-conducted hearing aid.
Yes, and I'm Dr. John Bennett in Miami with the website neurosurgical.tv. And we're going to just talk to Carlos today. And Carlos, so you're originally from Spain. Can you tell me, like you went in medical school, when did you first find out that you wanted to go into neurosurgery? When did you just feel that you wanted to go into neurosurgery?
For me, was when I was in high school. After that, I decided that I like to be a neurosurgeon.
Carlos, excuse me for interrupting, but I'm sorry to do this. Duccio, how you doing?
I'm okay. How are you?
Okay. Sorry. Yeah, we weren't sure what was going to show, but I'm glad you're here.
I'm sorry about that.
I'm glad you're here. I'm glad you're here.
Yeah.
And we'll go around again and quickly introduce ourselves to you. This is Duccio Boscherinia. He's from the Geneva area of Switzerland. And why don't we start with you, Nancy?
Hi, Duccio. I am Nancy Berquist. I'm in Colorado Springs, Colorado. I have a history in chiropractic, writing a PhD thesis regarding concussion, and I am a medical student.
Welcome, Nancy. Eleonora? You're muted, Eleonora. You're muted. There you go. Go ahead.
Thank you.
Okay.
Hi, Duccio. I'm a medical student in Rome, Italy. I'm a sixth-year medical student, so I'm finishing, and I'm interested in neurology.
Very good. Simon?
Good evening. My name is Simon Downs. I'm in Tokyo, Japan. I'm a developmental psychologist and a second-year medical student and FDA correspondent for a bone-conducted hearing aid. Nice to meet you.
And Carlos?
I didn't get that. Sorry, you are correspondent for?
I'm sorry.
Oh, I'm FDA correspondent for a bone-conducted hearing aid for hearing loss of 70 to 90 decibels.
That's interesting.
Okay, and Carlos?
Hello, I am Yumaguano Carlos. I am from Ecuador, and I was working in Hungary, and after that in Spain too.
Yeah, Carlos is a neurosurgeon. He's originally from Real Madrid, correct, Carlos?
Yeah.
Okay, and now he's in Ecuador teaching residents. Okay, and I'd like to introduce Duccio Boscherinia from the Geneva area of Switzerland. He's going to talk about the use of 3D intraoperative imaging in cervical spine injuries. So welcome, Duccio.
Okay, thank you very much. Well, I'm a neurosurgeon. I was trained in Switzerland, in Belgium, and the United States of America. And my main activity is spinal surgery, but I'm also doing some intracranial surgery sometimes. I was also I worked in Lugano. And I don't know if Carlos, you know Professor Ranella. Do you know him?
Yeah, I know. I'm working now with him.
Ah, okay.
Wow, it's a small world.
I used to be his deputy chief. He was the chief, and I was number 2. I was deputy chief in that department. Very eclectic person. Very special one. Anyway.
Yeah, I know. He's a very special man, and he's specialist, and the other people who is working with us here is Laura Botani from Italy.
Right. And okay, well, Shall I start with the presentation? Maybe.
Yes. Duccio, can you tell us a little bit about where you trained and where you're at now and stuff?
Of course. I was trained in neurosurgery mainly in Switzerland and in Belgium, and I was I did my part of my residency in Belgium, where I met my wife, and I had a full trainingship in Professor Brocci. He's retired now, but he used to be one of the specialists of intramedullary tumors. He also was one who introduced the semi-prone position for pineal region tumors, but he was mostly known for intramedullary tumors, and that was in the 80s, 90s. And my interests were diverse, I must say. I'm a fully trained neurosurgeon. At the beginning, I was, like many, interested in skull-based surgery. Then I did a fellowship in pediatric neurosurgery in Chicago, and I was also in Rome in Professor Di Rocco's department in the Catholic University in Rome. And then I turned to spinal surgery because I realized that more and more intracranial surgery was going to be, in a way, taken by other specialties. And the vascular, I remember the Bernard George doing some endovascular treatments of aneurysm, but in the 90s. But at that time, I think the battle was already lost, and most of the intracranial surgery was going to be treated by other specialists. So the spinal surgery has been my main interest, and I was the first one in Switzerland to introduce intraoperative 3D imaging in spinal surgery with the O-arm, and I think this really has given a lot of possibilities to navigation. And so the speech tonight will be on the use of intraoperative spinal 3D imaging in the spinal surgery, particularly in posterior spinal surgery. Do you have any questions?
No. Do you have any questions? Carlos is the most, probably the most, has the most knowledge of neurosurgery. So, Carlos, do you have any questions so far?
I'd like to ask what kind of intraoperative electrophysiologic monitoring do you use in spinal surgery, and what's the sensitivity and the effectivity of these kinds of monitorization?
Yeah, well, we use, first of all, one of the big debates in Europe and the United States are whether the neuromonitoring should be done by surgeons, anesthesiologists, or neurologists. That's one of the big debates today. And my personal opinion, and that's my choice, is that the neuromonitoring should be performed by specialists in neurology. More and more, you have these machines that are surgeon-oriented, and the interpretation is difficult. And because the surgeon is operating, by definition, you can't do both things at the same time. So it's quite difficult to do neuromonitoring at the high technical level without and operating at the same time. So to answer your question, indications there are mainly indications where it's absolutely, in my opinion, compulsory, necessary, obligatory to do neuromonitoring, as in intramedullary spinal tumors, intermedullary tumors, in severe scoliosis where you want to do correction, syringomyelia, and introduction of catheter in the spinal cord, or removal of tumors that even are at risk, like huge schwannomas, huge meningiomas, and traumatology where you have a main instability. And we had the cases where a signal was lost, just positioning the patient in the ventral position. So there are some indications where I really recommend, and it's becoming a sort of also medical legal standard. There are other indications where it's just relative, like I don't see the utility of monitoring screws, like you've got simulation screw devices, tests in a standard lumbar procedure. I don't see honestly the use of it. If you have 3D imaging, neuromonitoring, why should you use that? I think it's overconsumption. You're overkilling the technique. So my recommendation is indications are restricted to manipulation of spinal cord, whether it's traumatic, tumoral, vascular, or eventually degenerative with the scoliosis. And second thing is just make sure that you have a neurologist in the operating room that is acquainted with the technique, with neurophysiological monitoring, instead of having also being in a very delicate and ambiguous position where you would really, you have an anesthesiologist in the operating room that is not really fully trained for that. So in these complex monitoring, it's whether now sensitivity depends on, to answer your question, it depends on what you're dealing with. If you're dealing with motor evoked potentials or somatosensory evoked potentials, well, motor evoked potentials are definitely the most reliable, and if you lose SSEP during an operation, doesn't mean that the patient will have neurological deficits. So MEP are most reliable. It's also nice if you are operating on a patient in spinal surgery to know that at the end of the operation you will check the position of the implants with a 3D imaging monitoring imaging device like an O-arm or a CT scan, intraoperative CT scan like images. And at the same time, it would be interesting also to have the neuromonitoring that shows that after the operation, the signal is maintained, so that there is no neurophysiological modification after surgery and during the procedure, which is also something I think more and more medical legally speaking important. So that's my experience, and if you stick to these principles, you can't get it wrong.
Duccio, I just have a question. Since I'm a non-neurosurgeon, can you just bring us back to the history of 3D imaging, when it started? It wasn't too long ago, was it? 3D imaging intraoperatively? Well,
3D imaging started in not so long. If one should distinguish the neuronavigation and the 3D imaging. There are two different aspects of surgery. Navigation was introduced in the 80s in intracranial surgery. the point was using the preoperative images to navigate, to determine your position in the 3D, in the space. So the skull was blocked with the Mayfield clamp. The head was blocked, and so there was, and the acquisition of images was doing preoperatively. And on that basis, the good thing of navigation at that time was getting to a target without a lot of stress in terms of precision, and you could do many incisions in the skull. So there was no need anymore to shave the patient and to have a big exposition. So that really changed our neurosurgeon's life. Like small lesions, like a cavernoma, even deeply seated, or a tumor, and you had some doubts on the location, that helped a lot. From that point on, there was an interest around spinal surgery, of course, using navigation with the spinal surgery, and the screw started in the 90s, 1890s, and the cages were the intersomatic cages were introduced in the 90s. Transpedicular screw was getting was considered to be a sort of standard technique in the mid of the 90s, but still 2D imaging was the standard at that time. So that navigation was also based in the 90s on preoperative images of the CT scan and MRI, but CT. And what you had to do was sort of I have a presentation on that if you like. But
yeah, sure.
Okay, but it was doing a merging of the two, making a merging of preoperative images and what you saw in the exposed anatomy. But if you have 5, I can answer that. If you have.
Yeah, do you want to give that presentation?
Wow, yeah, that's what they're here for. But
okay, I thought you were gonna. Are you gonna show any slides, or you don't have to?
Yeah, I have some slides ready to show. Actually,
yeah, please. You know how to screen share, right?
Sorry.
You know how to screen share, right?
No, I can do this. Just a minute. I want to show you maybe.
Okay.
Maybe I want to show you. Well, I'll get to that. Maybe I'm just gonna finish my answer, but at the end, where I must say that 3D imaging changed surgeons' life. The reason is that 3D imaging made possible to navigate and to have an adjournment, sort of refreshment of images of what you were doing during surgery.
Okay.
The 3D imaging in spinal surgery made it possible to verify what really was the surgical procedure about.
Okay. Excuse me. The surgeon kind of watches himself where he moves his hands in his 3D surgery?
Can you say it again?
How does the surgeon watches his movements on the screen, so he's looking at the field and the screen back and forth?
Yeah.
Okay.
Maybe I can, if you give me a couple of minutes, I can find another presentation.
Okay. Do you use 3D imaging much, Carlos?
Sorry?
Do you use 3D imaging much down there in Ecuador?
Yes, yes, yes. So all people who are doing the spine surgery,
Yeah.
they must to do some kinds of preoperative image. But at this moment, in some centers in the world, they are using intraoperative CT or MRI imaging.
Okay.
But here in Ecuador, it is impossible to do that.
Okay.
And
okay.
In some parts of you must see how to develop the spine surgery. At this moment, we have a lot of kinds of techniques, like a preoperative, intraoperative, and postoperative management of this kind of pathologies. For example, in the intraoperative surgery, we can use neurophysiologic monitoring, like electromyography, somatosensory potentials, and motor evoked potentials. But all these are not very sensitive. This sensitivity is not high.
Okay.
So it depends in a lot of time from the blood pressure of the patient, what kind of anesthetics or sedatives drugs are using the anesthetist. So there are many factors that can be influence the sensitivity and the sensibility of these kinds of techniques.
Very good. Okay, Duccio.
Yeah. So the subject was presentation was on cervical spinal surgery and the use of imaging.
Okay.
And this what I want to say is that there has been a lot of advancement in terms of technical possibilities in cervical spinal surgery, and more what spinal surgeons do is they have long constructs, and because of that there's much more posterior instrumentation in cervical spinal surgery in different indications. In some cases we want to get to the vertebral artery region, and we also want to do big surgeries like deformity corrections in the cervical regions. And because of that, we need to put some screws in. So what I was saying about the history of navigations, in 1994 was introduced the navigation in spinal surgery based on preoperative CT scan. But what the surgeon had to do was a so-called point-paired registration. He had to open the spine, identify anatomically the structures, and then click on a pedal, click on a button, push on a pedal, and do a sort of registration compared to what he saw on the CT scan. So if he saw the spinal process, he was clicking on that. And this was awfully time-consuming and absolutely inaccurate. The inaccuracy was around 5-6 millimeters, which is really bad if you consider that diameter of the screws is roughly that. And so in 1998, what happened was we were looking for the a navigation that was paired to intraoperative imaging. So FluoroNav was introduced, which was based on 2D imaging, like fluoroscopy, and you had a pinpoint. So you had a fusion of the preoperative CT scan with the intraoperative FluoroNav. And we're really changed, and I think thanks to also much of the research and coming from GE, Siemens, was the idea of introducing the 3D imaging device. So here you have on the left side an example of a transpedicular approach with a navigation and 2D fluoronav, and on the right side the arm, which is the sort of mobile CT scan that is coupled to navigation, where you can simulate exactly what we're doing here. And so the screw gets into the pedicle, and the intraoperative imaging definitely makes registration easy and accuracy high.
Excuse me, Duccio, I don't think the slides are moving. Could you check on that, please?
Okay. Can you see now the slide?
Yeah, we're still seeing the first slide, so I think there may. There you go. There you go. There you go. Okay.
Can you see that?
Yeah. Actually, could you make it larger? Do you know how to make it larger? If you could, if it's easy to do. Yeah, that would be good. Can you guys see it okay?
Well, maybe I have another idea.
Okay. But the image is quite small. Yeah, it does go quite slow because the Hangout eats a lot of bandwidth. Whoop. We lost him. I hope he knows not to click on the... Now, Carlos, we're going to go back to your interview.
This is live TV, folks.
Live TV. It's like, yeah, it's like the set is falling down.
Yeah.
So, Carlos, did you say that you do use this intraoperative imaging in your work?
Yeah, yes. For example, in the intracranial pathology, we can use the intraoperative, for example, intraoperative MRI. In the world, for example, in Spain, in Switzerland, and Hungary, we have a 0.5 MRI, intraoperative MRI, and it's very important for some kinds of pathology, but not for all.
Okay.
There's a lot of radiation, right, Carlos? A lot of radiation, right?
Yeah. We have this intraoperative MRI is without any kind of radiation. So we must to have some kinds of protocols to use these kinds of equipment.
Very good. Duccio's back. Okay, Duccio.
Yeah, I'm sorry.
That's all right.
Line there. Okay, maybe I can show you the movement instead.
Okay.
Can you see my screen? Not yet.
Not yet. Not yet.
Can you see the screen?
Not yet. Are you clicking on the green arrow? You got it right the first time.
Can you see the screen now?
Not yet. You put it on the screen. You minimize the video and put on the screen what you want to show. Then come back to the video and click on the green arrow.
Can you see it now? No.
Not yet. No. Yeah, put on the screen what you want to show, leave it there, and then come back to the video on the taskbar, and then click on the green arrow. Look, you did it right the first time. I think you know how to do it. Yeah, remember? Yeah, just. Put your presentation on the screen. Like get off the video, click the minus on the video, put it on your taskbar. Put whatever you want to show on the screen. There you go. I think you got it. No. You can tell when you're not screen sharing. You can't see the green arrow. Duccio, are you clicking on the green arrow on the left side of the menu?
Yeah. Doesn't work.
No. Okay. Minimize the video screen. Get off the video totally by minimizing it. Don't exit, and then go to the. Put on the screen you want to show us, and then come back to the video screen. Okay. Are you still seeing the video screen? Like, are you seeing me right now? The big. Frustrated. Back to the interview. We got two things going on. Oh boy. There we go. Okay. We'll get it. We'll get it, Duccio. We'll get it. Okay. Yeah. Let's. There you go. You got it. You got it. You got it. You got it, Duccio. You got it. There you go.
Can you see it?
Yes, you can see it.
Okay. So this is the O-arm, and you can see this is a mobile CT scan.
Okay.
So the great advantage of this machine was not only was introducing 3D imaging in the operating room and coupling this machine to navigation. So it's not just a mobile CT scan, which is easily transportable, but it's coupled to navigation. So this 3D acquisition of the imaging is performed during I'll stop here. It's performed intraoperatively and coupled to navigation. And in this case, you can see also the neuromonitoring.
Okay. Are you playing the video, or what are you doing it now?
I stopped the video just to show the neuromonitoring.
Okay, because we're not really seeing the video move at all. Are you guys seeing the video move at all, or no? Are you guys seeing the video move? I don't think it's moving, Duccio.
No?
No, it's not moving.
Okay.
Is it moving on your screen?
Yeah.
Okay, well, is it moving for you guys? I can hear the audio now, but I can't see the video moving.
Can you see anything?
We can just see the screen of the video, but it's not moving.
Now I can see it.
Are you seeing it move, you guys, or no?
No.
No.
Maybe too many pictures and you can't show video.
Yeah, the video is kind of dicey. Yeah, sometimes it works, sometimes it doesn't. Pictures are better. The slides are better if you can put those on. So, Carlos, how many residents you in charge of?
Yeah, it's awfully naturally that this kind of situations presents when we are doing in a live presentation.
Yeah. Well, it happened. Are you teaching all the residents there at the school, or?
Yeah. We start with residents formation here in Ecuador for neurosurgeons, and in university University of Medicine, I give some like the studies from neurosurgery, neuroanatomy, and neurotraumatology. Here it's not a good organization here, but we can begin with the first stones here to do here in all kinds of formation. Here is not a good management of, for example, the traumatic brain injury. They don't have a good management, a good protocol for management on the subarachnoid hemorrhage. Don't have any kinds of protocol to manage the brain tumors, and spinal surgeon are very difficult to do something because some kinds of specialists want to do, like for example, traumatologists wanted to operate the intramedullary tumor, right. So it's in a very little
challenging.
Yeah. And well, for all kind for here, example, it in the pituitary tumor. Here is not operate before me, nothing or nobody operate like a neurosurgeon the pituitary tumor. Here doing the otorhinol yeah. But
ENT, I say.
Yeah, ENT. So this is not normal, not ordinary routes.
Right.
So we must work a lot of here in Ecuador. But I think for to have an experience in a very good case and a very good thing, I was decided to come here to Ecuador. Before I come here, I am not know nothing about the situations of health organization here in Ecuador.
Right.
So we have just the information that they given to us the Ministry of the Health here in Ecuador, but right. This was very bad. No, this was not enough. Not was really information about the situation of the health here in Ecuador.
Right. Yeah. Did they bring you there because they wanted you to show them new techniques or how things are done in Spain? Is that why you went to Ecuador?
Yes, we introduce here a new techniques here in Ecuador, but we have a lot of problems because an administrative and a bureaucratic challenge is very hard here. You must to find every day with all people to do they must to understand that the medical management is not the same like they are doing here in Ecuador.
Right.
And for example, we will initiate maybe in 2 or 3 weeks the functional neurosurgery. We will start to operate the Parkinson's patients. And here we don't have, before me, don't have any kind of medical structure, don't have any kind of devices. They didn't have any kinds of image preparing here, and we must do everything here. at this time I think I have to resolve so many problems. We will be start with this kind of surgeries maybe in 2 or 2 weeks. For other sites, for example, we must to organize the management of the traumatic brain injuries management patients, because here is not a good public management, because and in some hospitals they have some kinds of surgeons who will do some kinds of operations of traumatic brain injury, but in not all in the hospitals they didn't have any kind of reserves, and it's another war.
Well, you know what you said, Carlos, about you have to do everything, and that kind of goes back to what Duccio was saying. So in the 3D imaging, you have to do that yourself as well as operate. How does that work?
With the 3D MRI in the intraoperative management, they are doing in Spain in 3 parts, like in Sevilla, in Madrid, and in Gran Canarias. They are doing. But for example, the MRI devices just for 0.2, 0.3, and 0.5 Teslas. That is the accuracy of these kinds of pictures is not good, and if we can use these kinds of intraoperative images just in some kinds of pathologies, not in all of things. Like I think it's in a very good thing if we use, for example, in the tumor pathologies, when the objective of this is to resect the tumor totally, radically, because from there depends what will be the prognosis of the patients, what will be seen with the treatment, adjuvant treatments with the patients. In other kinds of pathology, well, maybe if they are using epilepsy treatment, in some kinds of epilepsy treatment, but this is the accuracy of the 3D MRIs is not very good. For example, in the spine surgery, maybe we can use but the health film that they give these kinds of intraoperative measures is a lot of big questions. What is the result for this? The navigation for this kind of pathologies, this is a very problematic thing that when you are doing a preoperative image with this kind of patients, you are in a supine position, and we are operating this patient is in the prone position.
Okay.
For that, for these kind of situations, the fiducial or the marks that we are used for this navigation will be changed more than half centimeter.
Right.
This will be not enough for having an accuracy in this kind for the localization of the pathology. For the other kind, for example, in the OR, on the intraoperative CT, this will be a very good tool for working for the spine surgeons, because you will be see the pathology in a live. You will be put some kinds of devices, for example, in the spine fixation instrumentation, in some kinds of pathologies, like on a traumatic pathologies, or in the degenerative disease. When you are doing an instrumentation of the spine, you can use the intraoperative CT or the OR, because you will be see the accuracy how you will be putting when you will introduce the screws into the vertebral body. For this kind, this will be very helpful. This kind of, but I think the intraoperative MRI, it's using is very limited because for the position of the patient will be changed. The image do it before and during the surgery, I think.
Yeah, one question I had when you mentioned and Dr. Duccio mentioned also was imaging with the screws. In my experience, they cause interference with the image, but that's not true with the 3D. You know how some metal can cause interference on the actual image? Does it cause that?
Yeah. For this case of when we will do some kinds of fixation of the instrumentation in spine surgery, we can't use any kind of MRI.
Right.
For the artifact that will be doing MRI, but with intraoperative CT or intraoperative OR, we can do it because we don't have any kinds of artifact. We will see very well the direction of the positioning of the screws.
Okay, yeah. I was kind of wondering what the interference. Simon, and Eleonora, and Nancy, you have any questions?
I've got a question for you, Carlos. Are you seeing that using this intraoperative 3D technology is reducing post-operative imaging?
I think no. I think no. We will be the cost of this kind of surgery will be very high. For two causes, because the devices is more expensive, and the time that will be used for this procedure will be more longer.
Okay. Do you see a reduced number of patients that have to go back into surgery though, because like say the screw placement was a little bit off, or do you see a difference using this 3D technology in the OR versus not using it, as far as patients having to return to the OR?
Yeah, in this kinds of if we use this kind of devices, maybe we will be assured to the patient that the some kinds of device will be put in a very good position, and the patient will not need to be operated another time. So for this kinds maybe, but if you have a good experience when you are doing very well the spine surgery, it is not necessary in all times to use intraoperative images, because for example, if you are using X-ray devices, you can do it because you can change the position of the X-ray devices in AP, in lateral position, and you can see very well. For example, I doing a minimal invasive surgery and percutaneous screw positioning in the vertebra just with the X-ray. I am not using, for example, an intraoperative CT or intraoperative OR, because the use of these devices are very high. The cost of the surgery will be very, very high. And the people in the public organization, they didn't will be paid for you these kinds of procedures.
I read a case study where the patient was C5 herniation or radiculopathy from a C4-5 herniation, and the surgeon went in and fused the correct area, but as they took an image in the OR, it showed it was in the wrong area, and the surgeon was horrified, and they used this intraoperative 3D, I think it was fluoroscopy that they used, and it proved that it was indeed the right level. So I just kind of wondered how often would that happen, or is it that decisive? I mean, have you been misled with conventional imaging, and then this 3D imaging quality is that much better?
Yeah, I think all developed in the medicine area is very well, because all of these kinds of tools will help to the work to the works for the surgeons and for the results to the patients. But you must understand that these kinds of develops, it's very high. It's very expensive. Will be not to be accuracy for the all patients in all countries. Maybe if we speak about this for example, in Europe, in the United States, will be normally. But if you are working in Africa, in South America, where the economy is not very well like in Europe or in the United States, we must to ask about that. Really, we can use these kinds of device, and how to change, how kind of results we will have. So we must think very about this. I think I like to work with a high quality, with a high devices. But if I have the possibility to use that. But for example, in this moment I am in Ecuador, and here in Ecuador, if I go to the hospital managers and say, please, I need arm. I will say, what's about the arm? We don't have any kind of money to back and a basic for drugs here. In some kinds, in some days, we don't have the possibility to buy some kind of drugs. This is the really situations in some countries. It's not the same like United States, Europe, for example, Germany, Switzerland, or Great Britain, and the situation is very different. You must to adapt to these kinds of situations, to these kinds of results that you will have in some times.
Well, you know, Carlos, if cost was not a factor, would you use it if you had it in all cases? Is it that much better results with 3D than non-3D?
I think this depends on the experience of the surgeons.
Okay.
It's a very simple things.
Okay.
If you are a driver and do you have a very pure quality care, you can drive in very well. Like I see maybe in a Chevrolet, maybe on a Suzuki. Maybe you will be driving very well. If for the next day you will be having a Porsche or will be having a Ferrari, what will you be do? You don't have any kind of experience to use these kinds of cars.
Yeah. Okay, but I guess in an experienced hands, so yeah, experience is a factor too, as well as cost and availability.
Yeah, I think who had a good experience with some kinds of, for example, if you speak about medicine, it's spine surgery. If you can operate very well, if you had a very good results with a basic devices, you will be having a good and a very well results with high quality devices like a 3D Intraoperative Imaging. Sure, but if you can't operate, if you don't have any kind of experience with the surgery, with the spine surgery, you can have any kinds of devices. I am sure that you will not have any kind of results.
Well, you know, Carlos, I guess laminectomy is probably the most common surgery in the spine, correct? Laminectomies for ruptured disc and stuff?
It depends what kind of pathology we will speak about that.
Yeah.
For example, if you have mechanical lumbar pain, stability lumbar pain, or you will have an stenotic canal of the lumbar, you will be more than a laminectomy. You will be doing a good fixation instrumentation of the spine, and you will have a patient very well results, asymptomatic patient, and this patient will be go back to the work. So, for example, in some kinds of degenerative disease like scoliosis, you must do there. You will not be doing an laminectomy. You will be doing as an alienation of the spine. So here in spine surgery, it's very important to do what about the pathology we will speak, what kind of the surgery we will do. Surgery is the spine pathology is a very high possibilities. We have traumatic pathology, degenerative pathology, tumor pathology here, and for these kinds of pathology, if we have the possibility to use some kinds of devices like intraoperative MRI, intraoperative monitorization. This will be good and a good idea. Will be good and a good results, but this is not possible in all countries in the world.
Yeah.
For example, in Europe, I always work, and I always work when I do in a spine surgery in Europe, and use intraoperative neuromonitorization. I am using intraoperative image like a fluoroscopy. I use an OR, but here in Ecuador, it is impossible to do that.
Well, just how about for just a common laminectomy, a lumbar laminectomy? Is 3D too much? You really don't need it? Just a regular laminectomy, cervical or lumbar for a ruptured disc. Do you use 3D, or that's really not needed?
Yeah, it depends. It depends what the extension of the pathology. In the lumbar region, the laminectomy, you can do it for 1, 2, or 3 segments without any kind of problems.
Right.
But if you are doing laminectomy in the cervical region, maybe you will have, if you're doing a laminectomy 1 or 2 segments or 3 segments, maybe the results will be very good in the early stage of the postoperative time. Right. But in the later time, after 6 months, after one year or 2 years, the patient will have an kyphotic formation for this kind of procedures. That is important to do in this kind of region, and a cervical fixation with screws.
Right. Okay. Very good. Simon, you're quiet over there. Wake up.
I'm awake.
Do you have any questions, fellas?
Well, before the presentation, I was trying to study up as much as I could on 3D imaging, okay. Interpretive imaging, and one of the questions I had was on the training, actually, for cervical spine surgery, and I looked at a study that said that the training is done on human cadavers. Is that true? Is that how you trained?
Yes, because who are the people or the surgeons, like orthopedic surgeons or neurosurgeons who are doing spine surgery, they must to have a good practice. We have possibilities in Europe to do and work at a cadaveric workshop every 6 months, every 1 year. We are doing. I doing these kinds of course in Madrid, in Netherlands, and in Amsterdam. I was in London to do these kinds. We must to do every time. So maybe 6 months or 1 year, but it's important to do that.
I see. Thank you very much.
Okay.
Carlos?
Eleonora, go ahead.
Carlos, yeah, did you notice that this 3D technology is easier to learn by the residents?
Yes, yes, I think, yeah. But you must do on a basic experience with the image interpretation, and after that, it's to have entertainment. It's about 3 or 4 months. You can learn to use these kinds of devices.
That brings up a good question, Carlos. Do you read the image yourself, or do you have the radiologist read it?
Sorry?
Do you read the image, or does the radiologist have to come in and read it?
No, it is not necessary to do with the radiologist.
Oh, okay. So you read your own.
Yeah.
Okay. That's part of the training.
Yeah.
Okay.
And Carlos, it's not just limited to spinal issues, right? You can use this on
cerebral,
any kind of orthopedic, ankle, knee, hip, whatever kind of surgeries.
Yeah, when you are doing this kind of surgeries, you must have an before preparation, and you will have, for example, to have a good how you can see this performing of the when you have to have some kinds of protections for that. In some kinds of this, we use or we need to work with some radiologist technicians, and after that they will be organized with all the people that who work in the OR. So we need to have a good resource for these kinds of devices to use here in the OR.
Okay.
Thank you.
Very good. You're in Quito, right, Carlos?
Yeah. Now I'm in Quito.
Okay. Do you cover a large part of the country, or you stay in Quito?
Yeah. Now I am just for 4 months here in Quito. I will be staying 6 months more here. I will be back maybe in July to Spain.
Okay. You'll be training residents there too in Spain?
Yes, in Spain too. I train the residents, but and this time I am doing here in Ecuador the training for residents here. For me, it was enough. I think 1 year here.
Oh, okay. Okay. You miss Spain.
Yeah.
Okay. Okay. Any more questions, guys?
No, really interesting.
Yeah, Carlos, thanks for filling in. I'm going to give everyone a refund here.
Yeah. That's too much.
Everybody gets their money back because I'm learning how to be a director, and I should have taken control and been a little better at the beginning. But anyways, we're learning. We're all learning.
Okay.
So I appreciate it, Carlos, for pinch hitting. You play baseball, right? You ever play baseball?
Who play baseball? I played baseball when I very young.
Okay, well you know what Okay, but you know what a pinch hitter is, right?
Yeah.
Okay, well you were a pinch hitter today.
Okay.
And did very well. We appreciate it.
Yeah, thank you. Hey, listen, Carlos is having a presentation tomorrow at 2 o'clock. If you guys want to come back, but it's in Spanish. I don't know if Nancy knows Spanish. Do you know Spanish, Nancy?
Not that well.
Well, if you're welcome to come if you want to come. And Eleonora, the Spanish is like Italian. I don't know if you understand Spanish.
But maybe you are speaking very well Spanish than me in English.
Okay, well, no, you speak good English. And everyone's welcome to come back at 2 o'clock. Carlos is going to speak. And tomorrow, what's the topic, Carlos?
Tomorrow is the cognitive change after stereotactic surgery in Parkinson's disease.
Very good, very good. I'll invite the neurologist too. So,
Yeah.
okay, well, I'm just going to hang around if you guys want to hang around, and if you have any questions or whatever. But I'm going to stop the broadcast.